My name is Leslie Morrison. I'm a physician at the University of New Mexico, and I'm a neurologist and specialize in pediatrics. I talked about cerebral cavernous malformations today, a genetic disease that affects Hispanic families in New Mexico, based on a founder mutation, an ancestral mutation that occurred hundreds of years ago and has resulted in a very large population of people, affected families in our state, with a blood vessel disorder of their brains and spinal cords. We presented today new hope based on some treatments that work in animals, that we might be able to someday prevent this disease from worsening in patients who've inherited the gene mutation.
How's everybody today? Yeah, it's a great day to be inside. Please turn your cell phones off, and we're going to ask that you don't take any screenshots of the program today or get your iPad and start doing this, because you just interrupt all the people sitting next to you. A couple of other announcements in July. On July 2nd, Miguel Torres will be here to talk about genealogy, DNA. Same place, same time, so we're looking forward to that. And then on June 15th through the 18th, I'll be up in Las Vegas. They're doing a Santa Fe Trail Descendant seminar, conference, whatever you want to call it. So they're going to have a lot of speakers and a lot of people talking about their ancestors who traveled on the Santa Fe Trail. I'm actually the keynote speaker, but I'll be up there all weekend. And once she's done here, I had it up earlier, we'll put the slide back up so people can get more information on that. Anything else? Oh yes, we have, NMGS has a new book out, San Juan de los Caballeros, the first book of a series of baptisms from 1726 to 1798. It's for today only. If you buy it right now, it's $40, and I have it in the back. Otherwise, the price is $50. And if you don't buy it today, you can also order it on Amazon. So turn it back over to Ron, and we'll get started.
One other announcement. I know some of you have followed the Genealogical Society of Hispanic America's annual conference. And this year it's again in Santa Fe at the Drury Suites on the first weekend in August. If you are planning to attend the whole conference, the Drury Suites is already sold out, so you would have to find another hotel if you plan to spend the whole weekend there. So Drury Suites is sold out. Is there anyone else who would like to make an announcement? If not, we'll get to our speaker, and I'll have to get my glasses first. Our speaker this morning is Dr. Leslie Morrison, and the title of Dr. Morrison's presentation is The Beginning of the End of Cerebral Cavernous Malformations in New Mexico. Cavernous malformations might be considered a genetic New Mexico disease. An attempt has been made to trace this malformation through DNA testing and New Mexico genealogy. This is Dr. Morrison's second presentation to the HGRC and/or the New Mexico Genealogical Society on this subject. On her last visit with us, Dr. Morrison also spoke about another affliction in New Mexico, myasthenia gravis, which causes droopy eyelids and mouth and difficulty breathing. I believe through genealogy it was traced to two Frenchmen. One is Victor Bordeaux. Dr. Morrison continues to provide clinical care for children with neuromuscular disorders and a large cohort of patients with familial cerebral cavernous malformations. She continues with funded research in both areas, leading a large study of 500 patients looking for genetic modifiers of disease severity. She continues to mentor junior faculty and students at UNM in research. Dr. Morrison received her undergraduate degree at UNM and practiced pediatric physical therapy for 5 years prior to attending medical school in the innovative problem-based primary care curriculum at UNM. She trained in pediatrics and child neurology at Johns Hopkins in Baltimore, Maryland. Please welcome Dr. Leslie Morrison.
introduction. It's great to be back here after 10 years. I actually met Joyce Gonzalez, who's going to be one of our speakers this morning. We have some little snippets for you. Joyce is then going to talk about her work with Henrietta Christmas on outlining some of the ancestors, some of the first ancestors with the disease. And then I'll finish up with what I hope you will find hopeful. So this is the rest of the story. So these are abnormalities in the brain and spinal cord. They occur because there was a mistake in one gene that occurs in chromosome 7. It was the first gene that was discovered to have a problem in this illness. There are now 3 known genes, CCM1, that's what we have here in New Mexico, CCM2, and CCM3. What we also know, though, is that they also can affect other systems in the body. The brain and the skin share a lot of genetic information, and so we also know that these can occur in the skin. And here are some examples. They can be tiny little purple skin lesions. They can be a little bit more speckled, kind of like this one. This one is actually like a blue blood vessel malformation, a vein under the skin. So everyone's looking at their hands. And they're actually a little bit more common on the feet and the hands. And here's one. This is of a patient whose mother has some on her hands. This patient has this on her elbow, and days before she had a cerebellar hemorrhage, her lesion on her arm bled. So very interesting, and almost made us think about, was this predictive? And then this is what they look like non-invasively. This is where Dr. Hart comes in. This is a patient he's one of our oldest patients, and we know that these lesions increase in number over time. So the older you get, the more likely you are to have multiple lesions. This gentleman has somewhere in the order of 700 to 800. This is just one little part of his brain. And then this is where the problem is. So we always think about AVMs, arteriovenous malformations, where there's a big artery and it combines with the venous system, so the pressure is much higher in this kind of a lesion. That's not what these are. These are low pressure lesions in the capillary bed, so what's kind of a normal area between the artery transitioning into the tissue and then coming out in the vein, coming back to your heart. These form these little mulberry-like structures. This pointer's a little difficult to use. These mulberry-like structures, and interestingly, they do even look like a mulberry when you take them out, or I like to call them moras because I have property up north of Mora. And this is what they look like then under the microscope. They have these dilated channels. Sometimes we see calcium in these channels, and sometimes we see blood clots in these channels. But the big problem is that when they leak outside of the malformation, this series of bubble-like, mulberry-like structures, they can be in a very bad location. And in the brain or brainstem, it's very high-priced real estate. If you have a bleed in those areas, they can be life-threatening or even cause death, as it did in Janae. So why are we talking about it here today? Well, it turns out that we have the largest population in the world that have this disease. And all of our patients, essentially all of our patients in New Mexico, share exactly that same gene mutation. We believe that this came from an ancestor in the New World, but we believe that this ancestor was of Spanish origin because all of our families have New Mexico ancestry, and Joyce is going to talk more about that. But the definition of this disease is that there are more than one. You start with one, but then multiple lesions occur, as I said, up until even your 80s or 90s. We expect people to be gaining more and more of these lesions. And then we know that it's familial. We define it as familial when more than 2 members of a family have multiple lesions, and also have sometimes, when we can find it, which is very common in New Mexico, a gene mutation that explains it. So what's written in the literature is there's a higher rate among Mexican Americans. Well, really, that is true. We also know that this occurred in northern Mexico in the states of Chihuahua and Sonora. But we think that it was still an ancestor who may have been in Santa Fe for a period of time, with multiple generations then staying in the state for many, many years. And we suspect it could be 300 or 400 years old. But it does not exist in Spain. It does not exist in southern Mexico. So it's very much our thing. It's here. One last thing on that slide, the last bullet point. These are what are called autosomal dominant inheritance patterns. And so if you have this disease, you have inherited it from one of your two parents. You're a genealogist, you know about this. And then you have a 50-50 chance, kind of the flip of a coin, whether you pass it on to your children. So in the case of Tim and Sandra, 2 of their 3 children got the gene mutation, and 1 of their children did not. And so we're very grateful to Jordan, who Tim explained, has also been participating in some of our studies as a normal family control. We know his exposures are exactly the same as Janae's and Joel's. So he's very good. It's very helpful to us to have people who don't have the disease that are in a family. So again, we have the highest density. We have the most people. We think we actually probably have more than 1,000 people with this gene mutation in New Mexico. We also know that only about somewhere between 25 and 50% of patients, actually about 50% of patients remain asymptomatic. They never show signs of the disease, which is very fortunate, but it appears in that way to skip a generation. It does not skip a generation, but you might just be a carrier of the disease. You may not manifest signs or symptoms of the disease. And then if you think about how there were, it started here, so families were very large, big Catholic families back in the day, and sometimes up to 20 children born to one mom. As everyone's shaking their head, yeah, you know the story. So even if some of them died, maybe some of them died of the disease, but for the most part they died of other things, mostly infections, or stillbirths were very, very common. We still had a lot of people, so let's say half of each family was affected by this disease, and then a next generation and a next generation, potentially up to 17 generations of families who mostly stayed right here in the southwestern area. So it became very much, we believe that it started somewhere in here. Somebody's father and mother probably had normal genes, but then at some point there was a mutation in that gene, which we think occurred in the New World, and then it just expanded and expanded and expanded. So we have this situation here, which is called a genetic founder effect. And so it's one of the 2 diseases that is very large in number, the other being not myasthenia gravis, but oculopharyngeal muscular dystrophy. So the other thing about this is that people, of course, stayed in the area for a long time. So we say geographic and cultural isolation. People spoke Spanish. People had a wonderful life. They had access to forests, they had fuel in the forest, they had meat, they could grow subsistence gardens, and so it was a great place for families to thrive. But today, we still have limited availability of care outside of Albuquerque and Santa Fe. So we are trying very hard to educate people around the state so that they have a better understanding of this disease. So what we have here in New Mexico is on chromosome 7, as I mentioned, and it is called the common Hispanic mutation. That's kind of the nickname for it. And it was discovered to be this founder mutation back in 1998, but it wasn't until 1995 where we first linked it to chromosome 7. And then finally in 1999, the actual mutation was found with our colleagues at Duke. And you know, since then, other mutations within the same gene of CCM1 have been discovered, many, many others. And then now, as I said, CCM2, which is on a different chromosome, and CCM3, which ironically happens to be also on chromosome 7. So these are Spanish legacies that have occurred in New Mexico. Like I said, we don't think that it occurred in Spain, but it was a Spaniard. And so we have also many beautiful things, you know, from the Spanish legacies, these beautiful churches and vigas and music, but we also have this gene mutation. And I'm going to ask Joyce now to get up and talk for 3 to 5 minutes or so about what she and Dr. Christmas have discovered with regard to the ancestors.
Good morning. My name is Joyce Gonzalez. I am Sandra Gallegos' first cousin, and I have CCM1, and I had spinal cord surgery. Some of you were here 10 years ago when Dr. Morrison and I, as she said, that's when we met, and since then have become good friends and started a path of doing a few presentations together and so forth on this illness. At the time that I found out of the illness, well, at that time I very quickly went into spinal cord surgery because the bleeds that I were having were in my neck area, and they were concerned that I might have a major bleed that could cause more extensive damage. And as Tim said, it took me about 15 years to even get to that point. But then about a year later, after I'd, maybe even less than that, started to go through recovery. So I'm a researcher at heart, started to research the illness, understand it more. I already had become interested in genealogy. I was already doing genealogy on my own family. So this thought I kept thinking, if it's a dominant gene and it doesn't skip generations, and I said, why can't we go back and try to figure out where this came from? It was just an interest in mine, and I hoped that somehow it might make a difference in the overall research and maybe helping families, you know, identify whether or not they might fall into the group. Now, you're all getting a copy of a chart, and I want to thank Henrietta Christmas because she definitely helped me do some of the research and correct some of the information that I have. As a matter of fact, we at certain times kept coming up. I came up with several different founding grandparents, but when we tried to pin in the people then that fit, that we all had to share a common grandparent. There was just no other way around it. And then not everybody fit into that group, so we kept working at it and working at it. My daughter was in medical school and she was doing a research paper. She helped me. She did a good amount of research. It helped me make some continuous process with it. But at this point, we feel pretty confident that we have come close, that we may have found the founding grandparent, unless it may still go up a couple of generations. But at this point, after about 10 years of research, this is where our research has taken us. Now, I want to say right off the bat, I bet you just about everybody in this room can say, wait a minute, I come from this family, but I don't think I have the illness. Well, here's what I'll say about that. Any one of us could have gotten the illness, but not every one of us did get the illness. Because just as in a dominant gene, just the way that it does not skip generations, let's just say a family like Dr. Morrison was talking about had 20 children. Well, it doesn't mean necessarily that 10 will get it and 10 won't, but it does mean that each child, like flipping a coin, heads you have it, tails you don't, each child had a 50% chance of inheriting it. Now, the other thing about a dominant gene is that if you don't get it, you're the tails that did not get it, you will never again, in your teeny tiny piece of the pie, you will never again pass it down. So it is ended. So, for example, I have a new grandchild, very proud grandmother, my first one. My son tested genetically negative, so I do not have to worry about that grandchild because it cannot be passed down, or his children and so on. It'll never be passed on. So in my teeny tiny piece of the pie, we have seen it end after about 400 years. That's not necessarily the case, like in Sandra's family, and I have several cousins, that have the illness, and a few aunts, and of course, we, continue to see it going down. Now, 10 years ago when I was here, I asked for help, and I actually got several people who called me, and we were able to, they helped me work through the process, continue looking on up the line, and getting an idea of where this illness came from. Again, today, I guess I will ask for your help again, because we have gotten as far as we have gotten, but there are still some family names that we cannot pin in, and one of them is the Martinez name that comes from the mostly like kind of the Rancho de Taos area. We know that there's a good population with the illness there, but we haven't been able to figure that out. The other thing that I'm suspicious, I don't know for sure, but I'm suspicious that although it's really come down to the Baca name, because Cristobal Baca carried the Baca name, or which then we also saw City Baca, Cabeza de Baca. Sometimes I think from some of the stuff I'm doing that possibly Maria, I can't even think of her name, I should have brought up a chart, Lara de Trujillo, that she is the one I'm thinking may have carried the gene. And it's just the Baca name that's come down. So oh, thank you, Tim. So yeah, Ana Morena de Lara Trujillo, and I bet you if there's probably, and I'm just curious, in this room, you're all genealogists, how many people come from this line? Yeah, that's what I figured. Probably the majority of you would. And again, that doesn't mean your family has it. That means someone in your family definitely could have it. But, so again, I ask for your help in that. If there's anybody who has a lot of information on the Martinez line, and if there's anybody that really has a lot of information on the Ana Moreno de Lara Trujillo line, that would be a really great help to me as well as we continue to look at this. I did have, down at the bottom, I do have my email address, so you have a way of contacting me. And the other interesting thing that I found, and I want to quickly, because I know we only have a limited time, but I want to quickly mention, as my research has gone on, at the beginning, everybody went into Manuel Moreno Baca. No, we couldn't find anybody going into any one of his siblings, and I couldn't understand it. How with, I can't remember how many kids they had, but 7, 8, whatever. How is it we were just getting one person? Well, when I did research on his parents, and I saw that after the Pueblo Revolt, they went to, the El Paso area. He was the only male Baca in that particular family who came back in the re-entrance in Santa Fe. So that was a big clue. But another thing that really became interesting to me is we finally were able to plug the Sanchez family that had this illness into it. His brother Ignacio Baca, even though he had a lot of children, I think it was like 12, maybe 14 children, they were really very ill-fated. Ignacio Baca died in the El Paso area. He did not come back, but his wife and his children did. Well, we finally, Mona Leonor Baca, maybe it's Leonora Baca, she came back, she married early at about 14, and she died in the second Pueblo Revolt of 1996. And 2 of her children also died in that, and I think the remainder of her brothers died at that time in that. So she only had one son left who did have the illness. And that's why a few families, and Jose Baca is another one, you probably know the story, that he got in a fight with his brother-in-law in El Paso, and he died over there, so he only had his one young daughter, which possibly our family comes from, which is Juana Baca, who came the reentry that obviously had the illness. So anyway, I'm going to leave it at that, and you do have my information. Please, I do ask that you contact me. You might have some really good information that would help me look a little bit further up and see where else we go with it. But anyway, I'll give it back to Dr. Morrison.
All right, forgive me if I run through some of these slides, but I really, again, appreciate very much all the work that Joyce and I have done together, as well as her husband, Greg, who has gone to Capitol Hill with us numerous times on trying to get funding nationally for our problem. So this is an interesting slide. This is obviously an old Spanish rendering, but 1766, so people were already here. And I use this to illustrate los frios, or the concept of what a seizure might look like. And so seizures are seen in about 1/3 of patients with this disease, as Joel has. And without neurosurgery, other than medications, there's no other treatment for them. So they're focal seizures. They come from one area of the brain where the cavernous angioma is close to the surface of the brain. And they can be managed with medication, as I said, but many, many patients who have seizures don't respond fully to medications, and so we do think it's important to take them out when we can, when they're accessible. Headache is very common. Sandra mentioned that she was asymptomatic, but she gets a lot of headaches. About 50% of our patients have headaches. Sometimes they have occasional headaches, sometimes they have a headache when they're having a hemorrhage, but many, many of our patients have migraines, and we treat them like migraines. I wish we had a better way to treat them, but we don't. And then finally, when there is a hemorrhage in the brain, it can cause changes in your neurological system. And so you might have either a temporary problem, weakness in one arm, or problems that resemble very much like a stroke. You might have paraplegia from a spinal cord lesion, or you might have some of these problems where you can't move one of your eyes out because this bleed is near the brain, in the brainstem of the body. This one causing facial weakness. This one where, if you could see a little bit more, you'd see that this baby can't move the left side. She's using only one hand because she's had essentially a stroke. Here's a brainstem lesion to illustrate that, and then some of the, what I would say, uglier versions of cavernous malformations that are very large and have a lot of remaining blood products that will probably never go away fully in the brain. And then the spinal cord, as Joyce said, hers was near the bottom of the cervical spinal cord, but Dr. Hart is recently completing a study which shows that we have a lot more people with spinal cord lesions than we expected based on the literature. So we are learning more and more, and this is actually an old slide, image the brain. So if someone finds a cavernous malformation in the spinal cord, we think they probably have the disease, and so that should lead you to also take a look at the brain, where we would probably find multiple. And this was the case in one of our families. We discovered it because he presented with a spinal cord lesion and of course had brain lesions too, and we found out that his father had it and the father's mother had it. So, and again, just another quick picture of the skin lesions. This one, very classic of the CCM1 variety. This was on the gentleman's thumb muscle, and they're very firm, almost like a hard edge to them. And here's another sort of speckly looking series of them. And so again, more and more as you get older, something to look forward to. And so that's the picture. That's what we see. Dr. Hart and colleagues have recently discovered that patients with this disease have calcifications in their adrenal glands. And that paper has been submitted for publication, and we're hoping that that's published in the near future. So why am I showing you this? Well, I wanted to point out my experience as an amateur genealogist of sorts, trying to figure out this disease on my own. I ran into so many difficulties. Well, if you look in Ancestry.com and you see somebody who was in, let's just say Rio Arriba County, maybe that was back in 1880 and it was Farmington. That's not where Rio Arriba County is anymore. We all know that in this room. So, you know, all these county borders have changed over time, making it very, very frustrating. In addition, lots of the Catholic Church records have been destroyed mostly by fire. And so, and the other thing is that, as I understand it, people often did not register their marriages because they had to pay for it. So they would wait until someone died in the family, and then that would be sort of the official church designation. They would prefer to be able to pay for their children's meals than to pay a priest to marry them. So those led to some lack of good documentation in our records. And again, we think that this came from ancestors who probably entered along the Camino Real and came up through Chihuahua and Sonora. Those are the only two states that we know of people who have ancestry here. And then on up into New Mexico. But of course, it was the borders that were changing, not where people lived. So people lived there in this area, north of here in particular, for many, many centuries. So it spread, and forgive me for including UNM as the hub, but we would ultimately like to become a center of excellence, a center of care, where we would be in communication with outlying community health centers and try to provide the best care possible through electronic means or whatever, in order to provide better care for people, since we have limited numbers of neurologists and neurosurgeons. We also have a very strong affiliation with a national, really an international group called the Angioma Alliance. And it's angioma because these started out as cavernous angiomas. And so people call them Angies, is a term of endearment. And so this is Connie Lee, she's the founder of the International Angioma Alliance, and this is her daughter. Her daughter, Julia, has type 3, CCM3, so it's a little bit different. It manifests a little bit differently. But this is a picture of her in Santa Fe. We've had several meetings here in New Mexico with international scientists coming here, and also for patient meetings. We try to hold a patient meeting almost every summer. And Santa Fe has been very generous in supporting events around this, and we actually have a Cavernous Angioma Day. What's it called, Joyce?
Yeah, it's informational Cavernous Angioma Day
Right, in Santa Fe, based on Representative Hogemeyer?
Yeah, Hogemeyer is the one who started that before she led City Council.
And as I mentioned, we started many years ago, after Joyce and I met, Greg and Joyce and Connie and I all met on Capitol Hill, and we visited all of our national representatives and senators. And Senator Tom Udall was very interested, and he's supported legislation on many, many occasions to try to help us out. I wanted to also point out we have a lot of educational efforts, mostly through our wonderful students at UNM. So here's just a smattering of different students over time who have worked on this project. Brenda Pacheco's now a PA. She came from Taos. B. Barrera is an obstetrician now in Espanola. And Jamie Derman's an emergency doctor in Tucson. I don't know the fate of Samantha Picrow, but that name may be familiar because her mother is a legislator. Ashley Hull comes from Santa Fe. Maria Ortega, she's the daughter of one of our chair of pediatrics. Christine Petranovich is working. Actually, she's probably not here because she's actually seeing a patient for research right now. And then Savannah Cheek, who's a very good friend of Janae's, as I understand it, is now also working on a grant that we just got from the Angioma Alliance, the national group, a micro grant of almost $10,000 to work on our question of why people don't participate in genetic research or in genetic testing. So it's going to be a key question, because without being able to identify people with this disease, we are not able to really expand our recruitment into our studies. So healthcare providers, we've gone around the state. We got a small grant from an alumni group, La Tierra Sagrada at UNM. We've educated patients and families, as I said, and then we are very intent on educating nurses, scientists, clinicians, community, and you are community. So we appreciate the opportunity. So what's happening, what do we have for treatment now? Well, as I said, I showed you the three things, the epilepsy, the headaches, and then the focal neurological problems. We really have very little to offer patients other than symptomatic treatment. In other words, you present with seizures, we can try to treat your seizures. You present with headache, we can try to treat your headache. But we don't have any way to prevent every year patients from getting more and more of these lesions. We don't have a way to prevent them from hemorrhaging. All we can offer is taking them out when they're neurosurgically accessible, when you can reach them without causing more damage. And so it's not a good scenario. Well, lots is happening though, and we're really, really turned on about this whole thing. So once we had the gene discoveries, people could take that gene and they could give mice a mutation. And then they had a perfect little controlled setting where they can manipulate different things for the mice and determine, what are the effects of various things. So I'm going to show you just some of those experiments that have potentially or will potentially lead to treatment. We have identified specific genetic patterns in patients who have the disease that are very interesting, because recently we found some of those same genetic patterns that they could control in mice. And so now we can go back to the mouse and treat the mouse differently and see what would be the outcome of treatment in a mouse before we try it in humans. We also discovered that obesity turns out to be one of maybe a protective factor, and that was very, very curious. We call it paradoxical, not what we expected. And it turns out that this may also be true in the mouse. And so we're really excited about that discovery and trying to figure out how we can link those two things. And it may be something to do with the gut, what kind of organisms live in the gut, and how we might be able to manipulate that. And then, as I said, modifiable changes in the mouse. We can treat the mouse in ways we could never treat a human and see what the effects of those are. So one of the discoveries is from a cardiologist, Kevin Whitehead in Utah. He and his group made a mouse, and the mouse had leaky blood vessels in the skin. And this was actually some time back, 2009. So after we learned this, we thought, well, and he because of the pathway, that molecular pathway that he identified, he was able to treat with a very common medicine, simvastatin. Anyone on simvastatin? Yeah. Or some other statin. So we thought, well, we'll go ahead and we'll see what happens when we treat humans without causing harm, because a lot of people were on statins. And unfortunately, when we did this experiment, we had a very hard time recruiting patients. It was a little bit more intense than a regular MRI. Treated them for 3 months on a fairly low dose of medication, and then we had a control group that we didn't treat. And we found that about half of the patients, whether they were treated or untreated, got better from the measure we were using, which was the leakiness, and about half of the patients got worse. So that didn't seem like a very good solution, very small numbers. There's a larger clinical trial now proposed on atorvastatin, not simvastatin, but a very related drug, and we'll see what the outcome of that clinical trial is. But we are now launching into clinical trials. We're actually treating humans in a controlled setting to try to determine what's making a difference. Here's another one. This is a researcher, Elisabetta Dejana from Italy, had been working in cancer work on what are called epithelial cells. So that's kind of more like skin cells, epithelium. And so she thought about some of the findings she was having, that maybe that would also apply to endothelial cells, so blood vessel cells, and that's where the problem is in cavernous malformation. And so what she discovered was that there may actually be potential for prevention based on this pathway that she was able to outline. This is why some of the cavernous angiomas or cavernous malformations get calcified. They change from one cell type to another cell type. And so but the good news about that is we can actually try to prevent that transformation. And then I just wanted to show you this little diagram. This is only part of the diagram, but all of this goes into how you make a mouse model with any specific disease. So this is just an example. This is not cavernous malformation. But once you have the mouse model, you can learn tremendous amounts of information from them. So this is a new collaboration that we have at the University of Pennsylvania through Dr. Mark Kahn's research group. And fortunately, I was able to tour his lab in April, and we're planning to collaborate and work on mouse. These are mouse brains to human. And here's what his discovery was. He discovered that he could make a mouse that got lots of cavernous malformations. This happens to be at the back of the mouse brain, the cerebellum. And he could fix it with various manipulations to cause other mice to be like this. Virtually no lesions. Well, that's our goal. This is exactly what we want to do in humans. And he discovered that he could prove that there were a couple of proteins very important in this transition. And if we could prevent those proteins, we would be able to prevent this situation and have more people be in this situation where lesions did not continue to develop and grow and be active. So we were very, very excited about this. And then finally, coming back full circle, I said this is the beginning. Is this the beginning of the end? So we now have some things that we can do in real mice and in real humans. We're beginning to get to the point where we may be able to prevent lesions from forming, lesions from growing, and lesions from bleeding. We can't change the genetics of a human, but we can take advantage of the knowledge that we're gaining from all of this mouse work and other animal work. And so I leave you basically with this diagram published on May 31st last year in the Santa Fe New Mexican based on Joyce and Henrietta's work that will help us to try to recruit patients who have the disease, that we will have more people to participate in our studies so we can continue to learn more about it. And finally, I want to thank mostly Tim and Sandra and Joyce, but all of the patients who we have about 300 patients, not 500 yet, but we have now expanded to 4 different sites. We have Phoenix, we have UCSF, and we have the National Angioma Alliance all recruiting for our National Institute of Health study. And now we're working at 12 o'clock. It's 11:30 now. At 12 o'clock, we're meeting to work with our patient partners, many of whom are in this room, and our scientists who are in this room, to create a grant that's patient-centered so that the outcomes are relevant and important to humans, family members who have been affected by this disease, and basically all of us in New Mexico. So thank you very much for your attention. We'll be